Good afternoon, folks. Take two on discussion A. We're discussing people's perception and misconceptions about death. Today for discussion A. So, have a presentation for y'all. So please sit back and enjoy. Here we go. Most people misunderstand how dying actually looks and what people want. It's usually a gradual bodily process rather than a symmetric moment. People's preferences vary widely, and early conversations make the experience less chaotic and less painful for families. What end of life workers say we consistently get wrong? End of life workers, hospice nurses, palliative care physicians, social workers, death doulas emphasize that the cultural script we carry about dying is almost entirely inaccurate. We imagine a quiet exhale, a final sentence, a peaceful fade out. In reality, they describe something far more human, far more physical, and often far more meaningful. Death rarely resembles movies. Workers repeatedly note that the body shuts down in stages. Appetite fades, sleep increases, breathing becomes more irregular, and the person may drift in and out of consciousness awareness. These may be There may be gurgling sounds, twitching, or railing. Bursts of energy shortly before death. These are normal psychological changes, not signs of suffering or distress. Families often misinterpret these changes as emergencies. Without preparation, loved ones may panic at breathing changes or unresponsiveness, believing something is going wrong. End of life workers stress that these are expected signs of the body completing its final work, not failures of care. People assume there is a right emotional tone. Many imagine the dying room must be uh, solemn, quiet, or re- event re relevant or re-event. But most workers say dying people often want music, laughter, conversation, or the familiar rhythms of the day of daily life. Some want a full room, others want one trusted person. The biggest mistake is assuming instead of asking. We confuse hospice with giving up. Hospice and palliative workers consistently report that families wait too long to accept supportive care. Okay, because they believe it signals surrender. In truth, early palliative involvement improves comfort, reduces anxiety, and often leads to better quality of life. Hospice is not about hastening death. It's about supporting living until the end. And pauses, shallow breaths, or long intervals between breaths. Skin changes, molting on hands and feet, cooling extremities, and color shifts as circulation slows. Decrease responsiveness. The person may not speak or open their eyes, but hearing often persists. Scenarios and sounds. The death rattle is common and usually not painful. It's a mechanical effect of the throat muscles relaxing. Workers emphasize that these signs are not are not suffering. They are the body's natural way of shutting down. What actually helps, according to the people who do this every day, talking early and specifically. The biggest regret families express is waiting too long to discuss wishes. Conversations about comforts, interventions, visitors, and spiritual needs reduce confusion and guilt later. Document decisions, folks. Document decisions about what the person wants at the end. Makes life a lot simpler for them, less stressful process. You want to see your loved one have as much happy time as possible, as much time as they can have in the short amount of time that their illness is letting them be with you. Advanced directives, forms, and naming a health care proxy, prevent crisis-driven decisions that may not reflect the person's values. Ask about ask about the environment, what music, what lighting, who should be present, should the TV be on. These details shape the emotional landscape of the final days that someone is with you. Those kinds of things matter to that person that is passing. Following their wishes gives them peace of mind, gives them the peace to let go when they have to, folks. Okay, normalize variation. There is no single good death. Some people want prayer, others want jokes. Some want solitude, others want a crowd. The best care is individualized care for when somebody is passing. One on one is the best for somebody that's passing, guys. That gives you time to focus on the person's needs, wants, and concerns before death. The next part, guys, is a quick guide for what to consider next. Okay, key considerations: symptom control, location of care, decision makers, cultural spiritual needs, legal paperwork, clarifying questions: who speaks for you if you can't? What treatment feels acceptable or burdensome? Where do you want to be when this process is going on? That means a lot too, where a person wants to be when they pass. Okay? The next piece is decision points. Appoint a proxy. Complete an advance directive. Ask your clinician about palliative care if living with a serious illness. Risk risk trade-offs and realities. Delaying conversations often leads to more aggressive medical interventions than a person would have chosen. Guys, if it's not written down what somebody wants, when you get them to the hospital or medical facility, they're going to try and save somebody's life. When you know a person doesn't want that, it has to be written down in their wishes. And their wishes have to be notarized and followed by somebody that really knows them really deeply and will be honored to follow their wishes. Because I'll tell you, that's not an easy thing to do, but I do it anyway. Okay. Honesty can be painful, but it has to be said. When a person is dying and wants to make a point across, you have to stop and listen to what they want when they're planning their own process. That makes a big difference to make them feel like they're part of the process. They're already scared about going, guys. What you have to do as people, as family members, is you have to help them pass respectfully. Okay, honesty can be painful, but it prevents long term regret and conflict among family members. Prognosis is imprecise, so value based planning is more reliable than waiting for certainty. You picked a rich one. This review is basically a map of how culture quietly steers almost every decision at the end of life. Here's the heart of it without the academic fog. Core question core question of the review, what it asks, what how do cultural beliefs, values, and demographics shape end of life? Palliative palliative and hospice care, especially decisions about truth telling, pain control, and where and how people want to die. What it uses: 25 studies, quantitative, mixed methods, and reviews. Focus on culture, demographics, end of life care, hospice, palliative care, terminal illness, and truth disclosure. Key themes the review identifies: cultural beliefs about death and dying. Different cultures frame death as a transition, punishment, fate, or taboo topic. This shapes whether families want full disclosure, prefer softened truth, or ask clinicians not to tell the patient everything. Communication and truth disclosure. Some groups value direct individual autonomy. Patients told first, full information. Others prioritize family centered decision making, where relatives filter or even withhold information to protect the patient. These differences can create conflict when clinicians assume one model fits all. Family roles and decision making. In cultures, in many cultures, the family, not the individual, is the primary decision unit. Elders, male relatives, or specific kin may be expected to speak for the patient. Ignoring this can erode trust and lead to low hospice or palliative care uptake. Pain management and opioids, cultural and religious beliefs influence. whether pain is seen as something to endure, a test, or something to aggressively treat. Fears of addiction, loss of control, or hastening death with opioids. This affects acceptance of palliative medications and can lead to undertreatment of pain in some groups. Use of hospice and palliative care. Misconceptions, e.g., hospice means giving up or they'll stop all treatment. Guys, it's the patient's choice whether they go to hospice or not. It's their choice what they want for treatments or if they want treatments at all. It's their choice. Historical mistrust of healthcare systems among marginalized communities, language barriers, and lack of culturally tailored information all contribute to delayed lower use of hospice and palliative services. What the authors say we're still missing: underrepresented groups. Many studies focus on a few racial, ethnic categories. Okay, next page. Perspectives, e.g., specific immigrant communities, indigenous groups, smaller faith, smaller faith traditions are still thin. Concrete tested interventions. We know culture matters. We have far fewer evaluated culturally tailored models for communication frameworks, family meetings, hospice enrollment, and education, trust building in historically marginalized communities. Political or practical takeaways for real world care. Ask, don't assume. Guys, ask the person with the terminal illness how they want things. Make sure the preferences are followed. When somebody's passing, all they want is families to be around them. All they want is somebody to listen, and all they want is somebody to follow their wishes when they pass. That's all. Okay, we are at don't or ask, don't assume. Use open questions like usually make who do you usually make decisions with, or how do people in your family usually talk about serious illness? Normalize different discussions models. Make space for both patient autonomy and family centered approaches instead of forcing one template. Build cultural humanity, not checklists. The review lends towards skills and stance, curio- uh, curiosity, reflection on one's own cultural lens rather than memorializing traits of X culture, design cultural tailored materials and workflows that include language access and visuals that reflect the community and explicit acknowledgement of mistrust and past harms. Okay, guys, that's A for you. What I'm going to do is I'm going to take a little break and I'll be back on with B for you. So for now, Gator Wellness. Take care, folks. I'll be back on shortly with B.